Krishna has completed a MBBS and MD General Medicine from Government Medical College, Trivandrum. He has also completed DNP General Medicine and has completed DM from APGME and our Kolkata. He has got specialty certificate in endocrinology apart from gold medalist in both general medicine and endocrinology. He has got multiple publications and authored various book chapters. Over to Dr. Akhil Krishna. Thank you.
Good afternoon to all, respected senior faculties, colleagues and dear friends. First of all, I thank Madam Sir and the team for inviting me. So my job is to deliver some of the aspects of oral semaglutide, one of the most recent drug which we have for the management of diabetes, especially for a subset of patients for whom this drug will be beneficial. So we'll see some disclosure. So let us start with a case. This is a 38-year-old bank manager who had a recent executive checkup for some kind of tiredness and some kind of cosmetic symptoms. His BMI is 36, so as per the Southeast Asian guidelines, you can see that he is having obesity grade 3. His blood pressure does not have any history of hypertension or any other comorbidities in the past, but his blood pressure was measured 170 over 100. And his glycemic parameters are alarming: fasting of 310, postprandial of 420, and HbA1c of 14.5. Liver enzymes are elevated. We take a cutoff of 30 for the liver enzymes, it's 80 and 68. And the ultrasound of the abdomen showed grade 2 fatty liver. And his lipid profile was showing a typical diabetic dyslipidemia pattern: raised triglycerides, low HDL, and raised LDL. So this is what the numbers show to us. So he was not on any previous medications, no history of alcohol consumption or smoking. He was not physically active. Considering his job also, he did not find any time to do any physical activity. So what will be offered to this gentleman who is coming in for the first time? So our concerns are newly type 2 diabetes with an HbA1c of 14.5, grade 3 obesity, MASLD. There's a new terminology which has replaced the NAFLD. It's metabolic dysfunction associated steatotic liver disease, dyslipidemia, hypertension. So our priorities are: one should be glycemic control. He need to lose weight, manage this steatotic liver disease. We have to control other associated comorbidities like lipids, blood pressure, and most importantly, we have to prevent an atherosclerotic cardiovascular event in this gentleman. At least now he does not have a clinically evident ASCVD. We need to prevent an event in the future. So these are our priorities for management. So this is the typical triad or the unholy trinity of obesity, diabetes, and CVD, with which we see in our OPD in our day-to-day practice. Just some numbers to familiarize: 88% of people with diabetes are living with overweight obesity. Nearly 1/3 of people with obesity are living with type 2 diabetes. And similarly, due to diabetes and CVD, the majority of the deaths in diabetes are because of cardiovascular disease, around 50%, and 30% of patients with cardiovascular CAD have diabetes. Similarly, the numbers are matching with CVD and obesity as well. So whenever we manage a patient with diabetes, if you see the evolution of the ADA guidelines, you'll understand that we are just not focusing on the glycemic management now. We are now focusing on a multifactorial approach where we have to consider other associated factors also. And when we choose an agent for this patient, we are not just concerned about the numbers of the FBS, PBS, or HbA1c. We also need to consider their weight, their other associated comorbidities, especially the cardiac and the renal parameters and the history of the patient. So GLP-1 RA, which is my focus now, is having an impact on multiple parameters which the patient which we discussed is having regarding the glycemic control, reduction in the body weight, blood pressure control, reduction in the inflammatory markers, and they have multiple cardiovascular benefits as well. I'll come to those in a while. So you are familiar with this slide, that is the American Diabetic Association's the flow chart for the management of diabetes. Just I want to focus on a few points. A patient with ASCVD or with high risk of ASCVD, we need to have these drugs in the prescription. SGLT inhibitor, unless contraindicated, GLP-1 RA if the patient is affording. Second, if the patient glycemic parameters are high, we need to choose agents which can bring down their glycemic levels. That is, the potency of the drug is important. And they have added this, that is the weight management also, because the recent years the obesity management has changed with the introduction of GLP-1 RAs. So we have to address this parameter also regarding the weight of the patient when we are managing diabetes. So regarding this, the GLP-1 receptor agonist, dulaglutide high dose, which is not available here, semaglutide and tirzepatide. These are all injectable, which they are given in the guidelines, have high potency drugs for the management of diabetes, and they are very high efficacy for the management of body weight also. These two are the injectable preparations which we are yet to receive. It's available in the outside markets. Many of our patients are procuring from outside and they are taking it. But what we have to offer, what we have in our monitoring is the oral formulation of semaglutide. We all know this famous ominous octet by the famous Dr. Ralph DeFonso. So the impaired glucose insulin secretion, increased glucagon secretion, increased hepatic glucose production, impaired appetite regulation, decreased glucose uptake in the periphery, decreased incretin effect, increased lipolysis, and increased glucose reabsorption at the level of kidney. These are the main 8 cardinal pathophysiological defects in diabetes. So when we manage a patient with diabetes, we are trying to address these 8 pathophysiological aspects as well. We have multiple drugs addressing multiple of these pathophysiological defects, and GLP-1 RAs addresses around 6 out of 8 defects in patients with type 2 diabetes. So regarding GLP-1 receptor agonists, we have human GLP-1 based therapies and exendin based therapies. The human GLP-1 therapies are basically either weekly or daily dosing. Weekly, they are injectable dulaglutide and injectable semaglutide, subcutaneous injections. Daily, we have daily injectable liraglutide and oral semaglutide. And this is the only available oral formulation of GLP-1 receptor agonists we have today. Exendin-based therapies, which we don't routinely use, that is the subcutaneous extended extended release or the daily formulation, and the lixisenatide. Coming to semaglutide, it's a human GLP-1 analog. It's having around 94% homology to the human GLP-1. The T-half is approximately 1 week. So if you see the structure, they have altered some amino acids to improve their, to protect against the degradation and all. What is more important is, we all know peptide drugs cannot be given orally because it gets digested inside our gut. So how this oral semaglutide was made into an oral, this peptide was made into an oral drug. That was one of the landmark revolutions that happened. That is with a co-formulation with an absorption enhancer, which is known as SNAC. SNAC, the full form is given here. So semaglutide, when it is coupled with absorption enhancer, it can achieve this adequate bioavailability after oral administration. It's actually a small fatty acid derivative which will enhance the absorption across the gut epithelium. And around 300 milligrams of SNAC is co-formulated with the semaglutide to enhance its absorption. So this is how the SNAC facilitates the transcellular absorption of semaglutide. Even then, only 1% of the administered semaglutide gets into our bloodstream. So the bioavailability is still low, but that is sufficient to exert its therapeutic benefits. So that is why approximately 0.5 milligram of weekly injectable semaglutide is equivalent to 7 milligram daily oral semaglutide, and weekly 1 milligram of injectable semaglutide is roughly equivalent to 14 milligram of oral semaglutide. That is from the bioequivalent studies. So what is the evidence with oral semaglutide? It is shown by the multiple pioneer programs. Pioneer 1 was a placebo, against placebo, and Pioneer 2 to 7 was against oral drugs, and in insulin users also they had multiple programs. So these pioneer programs actually clearly showed the therapeutic benefit of oral semaglutide. So coming to a few details from the pioneer programs, the glycemic efficacy. If you see across the pioneer programs, whether it be monotherapy or compared to other drugs like EMPA, Sita, Lira, or in other groups of patients, the rough HbA1c reduction was around 1.5%. But remember, it depends upon the initial HbA1c level of the patient also. If the patient had an A1C, high A1C to start with, their HbA1c reduction will be more. So what is the effect on body weight? Across the pioneer programs, you can see that the three bars which are shown here, that is with oral semaglutide 3 milligram, that is what is the dose which we start with. Then we usually step up to 7 milligram and then to 14 milligram. So 14 mg is the dose which is having maximum effect. You can see the weight reduction is somewhere around 5 kg. It depends upon other parameters also. So how much weight loss is needed to improve the health? So if you need to improve the measures of glycemia and the triglyceride, around 3% body weight is sufficient. Body weight reduction again. Around 5% body weight reduction can improve the HDL cholesterol, blood pressure, hepatic steatosis, and measures of feeling and function. If you can achieve more body weight reduction, around 10% or more, the NASH activity scores improves, apnea-hypopnea index improves. If you need more hardcore outcomes, more than 15% body weight reduction, you can have reduction in the cardiovascular events, reduction in the mortality, and even remission of type 2 diabetes is possible with a reduction of 15% or more of the body weight. So, what is the effect of oral semaglutide on CV outcomes? We have FDA mandate that any diabetic drug should clear the cardiovascular safety study. So this is the Pioneer 6 dedicated cardiovascular outcome trial with oral semaglutide. This was a non-inferiority trial just to prove the safety of the drug, which showed that in the primary 3-point MACE, there was a 21% non-significant risk reduction. This was non-inferior. This was a non-inferiority trial. There is an ongoing superiority trial with oral semaglutide, that's a sole trial, that results will be published maybe in few years' time. So apart from these benefits, does oral semaglutide offer any other benefits? So in addition to that, we have benefits with regard to the lipid control, waist circumference, blood pressure, inflammation, and so on. So semaglutide reduces around 4.7 centimeters waist circumference compared to placebo. It also reduces the calorie intake by around 35%. Oral semaglutide also reduces the systolic blood pressure. You can see around 5 millimeters from the baseline compared to 2 millimeters to placebo, and it has got its own benefits. It improves the lipids, it improves or reduces the vascular inflammation. So now the question is, what is the mechanism of action of oral semaglutide? The proposed mechanisms include the incretin hormones. It decreases the food intake by acting at the level of the brain through various neurotransmitter modulation. It can act at the level of the GIT to reduce the gastric emptying. It acts at the level of pancreas on both alpha and the beta cells, improving the glucose-dependent insulin secretion and reducing the glucagon secretion. Decreases hepatic gluconeogenesis and decreases hepatic steatosis, and improves the insulin resistance at the level of the muscle and the adipose tissue, increasing the insulin sensitivity and increasing the glucose uptake. So it acts on multiple levels and improves multiple glycemic parameters as well as other beneficial effects it has. So if you combine this GLP-1 with SGLT2 inhibitors, it's an excellent combination. With regard to mechanistic benefits, it has got benefits at the level of metabolic levels, renal, cardiovascular, and multiple benefits are seen. And this is a combination which is recommended across the guidelines for various cardiorenal benefits. So therapeutic benefits, when we combine these two drugs, it addresses the residual risk, better myocardial salvage, post-myocardial infarction, reduction in the risk of EGFR decline, reduction in the MACE and all-cause death, lower risk of end-stage disease, and more cardiovascular disease-free life years. Suffice to say that it improves the cardiorenal profile of the patient significantly. So this is the ongoing trial of semaglutide, the SOUL study, which is a superiority trial of oral semaglutide, the cardiovascular outcome trial, and there is other trials like ASCENT plus trial. So we are expecting the results in few years. It's a basic trial design of oral semaglutide SOUL study, 14 mg with standard of care versus placebo, and the primary endpoint is cardiovascular death, non-fatal MI, non-fatal stroke. And the baseline data are shown here, that is the patients who were on the other group of drugs, the patients who had baseline CAD, CVA, peripheral blood disease and so on. So the real world evidence on oral semaglutide, we can see from this real world study, there is A1C reduction, good A1C reduction, and this drug has been accepted as a drug of choice for managing early diabetes in India. The mean baseline A1C was 8.9%. 90% was started for achieving better glycemic control and weight control. 1 in 5 patients were started oral semaglutide within 1 year of diagnosis, and 1 in 2 patients had CVD-related history, stressing the need for effective treatment options. So, in line with this, in my hospital, we had a Kim's Health Metabolic Clinic, a 5E model, where we engage patients through this flow pathway, where we are basically addressing the cardiometabolic risk of the patient, especially in the patients with diabetes who are having associated obesity. We evaluate the patient, starting with the examination. We check the Edmonton obesity risk score. We assess the etiology and comorbidities. We rule out other endocrine causes of obesity. Educate means eat healthy. There is a dietary advice, exercise, and the emotional assistance. We usually, for the endocrine pharmacotherapy, the most effective drug which we have is the GLP-1 receptor agonist, of which we most commonly use oral semaglutide. Endobariatrics are the bariatric procedures, the balloons and all, the temporary procedures for the weight reduction. And those patients who qualify for the bariatric surgery, we seek help from the bariatric surgeons. So this is the metabolic clinic model. So coming back to our patient, this patient, what can we do? So these are the baseline parameters. The patient is started on a premix insulin because the patient was having A1C 14.5 osmotic symptoms. A premix insulin with suffice to say we have to advise diet, exercise. Metformin was started 5 times then exceeded 1000 ml twice daily. Empire was 25 milligram. And the patient was started on oral semaglutide as well. Started 3 milligram, then escalated at 4-week intervals to 7 mg and then to 14 mg. 6 months down the lane, the patient has lost around 14 kg. The glycemic control, the glycemic parameters has almost normalized or within the accepted reference ranges. The patient was initially started on 3 antihypertensives, and now the patient is on 1 antihypertensive. The blood pressure is well under control. The liver enzymes have normalized. The patient was started on rosuvastatin 10 mg, and the lipid parameters have also normalized. So the patient had, after 1 or 2 months, the insulin was stopped, and the patient is just on the oral medication with the dietary advice and the other associated drugs for blood pressure and cholesterol, and the patient is physically active now. So to summarize, oral semaglutide has got multiple benefits apart from the glycemic control. It is the only oral GLP-1 receptor agonist available now. It has got weight reduction benefits on the cardiac as well as renal parameters. Metabolic dysfunction associated steroid levels, MASLD. There was a phase 2 trial with injectable semaglutide. There was an ESSENCE trial for the phase 2 trial for the injectable semaglutide, and the phase 3 trial is ongoing. So we'll have more data on MASLD with oral semaglutide also, sorry, injectable semaglutide also. So thank you for your patient listening.
Any questions?
What is the cost of oral semaglutide for a month?
Regarding the cost of the drug, actual monthly cost will come somewhere around 9,000 to 10,000. But when we talk about the cost of the drug, what we have to understand is that many of our patients who are on insulin with multiple other drugs, for example, if the patient is on a premix insulin like 25% is Promix, one vial costs around 1,000 rupees. If the patient is on 30 units morning, 20 units at night, the insulin cost itself will come around 5,000 per month if you calculate the MRP. If a patient is started on oral semaglutide, we can reduce the insulin dose significantly. Many of our patients who were on insulin higher dose to start with, they could be brought down to a minimum dose of insulin, or many of the patients could stop insulin later on. So even though we talk about the cost of the drug will come around 10,000, but the associated co-prescribed drugs cost will come down significantly. Not only insulin, other antihypertensive drugs will come down. The number of drugs we can bring down. The statin dose can be brought down, and the other co-prescribed the oral antidiabetic drugs also we could reduce. So overall, when we calculate the cost in the long term, the extra cost will come somewhere around 4,000, 5,000 max.
Thank you. Cut down the cost by another 3,000 or 4,000 for the same effect. Is that it is a big?
It does not have the same effect, madam. The literature does not support your statement. Semaglutide is far more superior than liraglutide, even though liraglutide costs few thousands less. Maybe some generic formulations are available now, but even that is out of supply now. So, but if you talk about the benefits, if you talk about the evidence, semaglutide has far more data and it's far more superior compared to liraglutide.
So, but if the BMI is low on the side, say just 25, we still lose weight again with the semaglutide.
Sorry, sir.
If a patient's weight is on the lower side, BMI is low, around 25 less than that.
Yes.
We put him on semaglutide for its CV benefits.
Yes.
Even in that case, we lose weight.
Yes, sir. The weight reduction, yes, for lean patients, the weight, when we escalate from 7 mg to 14 mg for lean patients, it may be difficult. But at least 7 mg of semaglutide is needed for the cardiorenal benefits. So for lean patients, we may not use it that commonly. Even though we talk about lean patients, they may be lean from outside. They may be, we have thin fat Indians, maybe fat from inside, they have reserved obesity. So in those patients, maybe we may have to consider lower dose, or we can use other drugs like steroid inhibitors and all, which does not produce that much weight reduction.
And what's the incidence of nausea and bloating of blood extras?
Yes, it's a common side effect, yeah. But proper patient education can reduce the side effects significantly. So what we usually advise to the patient is that eat in small portions, eat small meals, reduce the oily, spicy foods, oily food should be reduced. And once you feel full, you have to stop eating there. For example, if you take 2 doshas and you are full after one, don't take the other one also just to finish the meal. Because if you take that, you will have that nausea and vomiting feeling. So these kind of advices if you give to them. And what I usually practice also, in the initial period when we start the drug or when we escalate the dose, I usually give PPAs also for 1 or 2 weeks time just to have confidence with the drug. Then most of the patients are, but still the discontinuation rates will be, if we start for 10 patients, 1 or 2 patients may drop out because of this GI side effects. But majority of them, but most of the side effects are the initial starting phase or the up-titration phase, and later on, usually the patient tides over if they follow the proper stabilizers.
Thank you. For want of time, we are going to move on. I would like to invite our chairpersons to felicitate our speakers. I would like to invite Dr. Kumarvil to felicitate our chairpersons. You're all welcome to enjoy our sumptuous lunch and hopefully not think about semaglutide. And please be back by 2 o'clock. We will be starting our last session for the day sharp. Thank you.